Fine, 303, I'm feeling antsy. So I'm going to get rolling. So thanks everyone for coming today. This is our IQ Forum, formerly known as the KCQVIC Forum, which is a program of the Healthcare Institute for Innovations in Quality. I'm Stacy Farr, and I'm really excited to introduce speakers and tell you a little bit more about the Institute before we do that. So, first I just wanted to share a little bit about the Healthcare Institute for Innovations in Quality. We have this vision of Kansas City really delivering the highest value, most equitable healthcare in the nation. And our mission is really to catalyze and facilitate multi-stakeholder collaborations to improve the quality and value of healthcare in Kansas City. And we work with and are supported by a number of partners, and many of them are listed here below on this slide. So thank you all for being a part of this. And so, this is a little bit of background that I think everyone is, probably aware of by now. But as we all know, in the U.S., we're under these shifting healthcare payment models where we're really moving from volume-based healthcare or fee-for-service medicine into value-driven healthcare, where we can actually decrease costs of care and deliver higher quality care. And health systems, payers, these stakeholders don't really know how to navigate this space yet. It's definitely a struggle learning how to move in under these shifting payment models. And we've developed this regional strategy where we bring together a number of stakeholders, including providers, researchers, purchasers, the payers, different community partners, and patients, where we can all kind of think about this together and work together so that we can make a larger impact. And we have, within the Institute, we have really three main legs of our stool, so to speak, that we stand on, and our three main buckets of activities. And so I'll just highlight these for you briefly. So we have our first is our regional quality improvement projects. And so this is where we spend and bring together a number of stakeholders in Kansas City to really talk about what are the most pressing and urgent needs in Kansas City that we need to collectively do and impact. And then what we do is work with the health systems, the hospitals, the payers, and the other partners so that we can implement and evaluate those projects and really do action in terms of meaningful quality improvement. And so our two main projects that we have right now are the opioid project, which is KC Epic, as well as transitions of care for heart failure. And as many of you know, we are looking to start producing some findings and results from the opioid project and hope to bring that project to a closure by the end of this year so that we can move into regional project 3. And I don't know if I should be saying what it is now, but I think many of you do know, and we've alluded to it in the past, but we're probably going to be looking at reducing maternal health disparities and improving maternal health inequities. So that's our next foci. And then our second leg of the stool is really around training and education. And in order to actually do this implementation, this quality improvement work with hospitals, and we really recognize the need that we need to have people trained and how to actually do that. And so we have a training program really which teaches the basic science of quality improvement that is informed by implementation science. And this is extremely hot right now, and it's just well in demand, both for providers, for researchers, for others who need to learn this skill. And so we built Tiara, we offered it in, I want to say 2018. We've kind of repackaged and built it. We're refining it, and we'll be launching that again in January of 2024. So that will be both as a live, if people want to enroll and take it, as a cohort together, as well as a self-paced course. We also have online courses, graduate level courses through UMKC that we teach as an alternative option. And then we have our dissemination and engagement arm, which is our IQ Forum primarily, which is where we all are here today, where we bring together a number of stakeholders to talk about a number of healthcare pressing issues in our region so we can think together, get outside the box, get outside of our silos, and really think about ways we can improve Kansas City together. So very excited for today's session on the role of data and the evolution of healthcare. This is an extremely timely topic, really important. We have some really great speakers. And so without further ado, I guess I will introduce our first speaker. You can see the lineup here on the agenda, so I don't need to repeat it all, but we will be starting with our health econ research perspective from Dr. David Slesky. And so I will now turn the floor over to you, David. And I'll stop sharing.
Great, thank you so much. Can you all hear me?
Yes.
Mm-hmm.
Excellent. Okay, here we go. So I'm David Slesky at the University of Kansas, which you can see here. You're all welcome. Let me know if you're ever in Lawrence. Lots of great food here. And I'm going to talk about how data makes health economics research possible. I think there's so many new amazing data sets and data linkages that have made a lot of research possible that previously really couldn't be done. I want to put in context what I mean by health economics relative to some other research that happens here. So I think that medical science and kind of health science broadly does two things well. They do randomized controlled trials like this one, the product of which is probably in many of your arms from the COVID-19 vaccine, but also does kind of large-scale correlational studies. I think most famously, perhaps, the 1960s Surgeon General's report on smoking. But what health economics, the kind of health economics I do, I think really adds is natural experiments. So we won a Nobel Prize for this in labor and health economics a little less than 2 years ago. And these natural experiments need data. If you just have variation or some kind of experiment without data, you really can't say anything. So what I want to do in a brief talk here is just bring you through some of my favorite papers in the last couple of years and the amazing data sets that made them possible. And let us answer some questions we otherwise couldn't answer. We'll start with a bit of my work on ride sharing availability and ambulance use. We'll think about what kind of physician you get in the ER and how that affects future opioid use. We'll look at contact tracing for COVID-19, and we'll look at abortion access and financial circumstances. We'll think about the Medicaid fee bump and physician income. And also, I'm an economist. We love being interrupted. We love interrupting, and so therefore we love being interrupted. Please, you're welcome to just unmute and start shouting or start shouting from the back at any point. This is a lot more fun the more we get to talk here and later in the session. And I'll put my contact info at the end. You're all welcome to reach out, especially those of you who are Kansas taxpayers. I work for you. So please reach out and stay in touch, and would love to continue this conversation. Okay, so Uber rollout. So I moved here in 2014. We didn't have Uber in Lawrence when I moved here. And now we do, which actually has changed how my family drives and how my family gets around. And so we wanted to think about the relationship between that and ambulance usage. So we noticed that Uber's website would tell you every time Uber became available somewhere and actually show you the map. And with that map, we hand-coded what zip codes had Uber and what didn't when. And this, you can look, this is across the United States. These are all the metropolitan areas that got Uber. And it really ranged over about a 2.5-year period. We then took that data, we matched it up with NEMSIS. Some of you may be familiar with NEMSIS, which is this amazing data set of ambulance volume in different regions across the US. We merged it with their data, and we looked within locations over time and found, this is an event time, this is not calendar time, this is quarters before and quarters after Uber became available. We found that ambulance volume declined by about 7% when Uber became available, right? And this then brings up lots of conversations about what is the right mix of emergency medical transportation, right? That an ambulance is a very, very resource-intensive mobile ER way of getting somebody to a hospital, but maybe we have a whole spectrum, right? Maybe you could video call 911, and then they would, you could send to the feed from your Apple Watch, and maybe they would say, call us in the morning, and maybe they would say, we're sending an Uber driver, maybe they would say, we're sending an Uber driven by an EMT with the first aid kit, maybe they would say, we're sending a cop car with lights and sirens driven by an EMT, or maybe we're sending an ambulance, right? It makes you think about what is actually a way to deliver care more efficiently. Okay, I'm gonna go quickly through these, but happy to answer questions later. Opioids, we all think a lot about opioids, a lot about deaths of despair. So this is a paper, it was in New England Journal a couple of years ago, that looked at the distribution of ER physicians' propensity to prescribe opioids when you show up in the ER. This is in Medicare data, right? You show up in the ER, you don't know who you're gonna get. And so you might get a physician that is quite conservative or might get one that is quite liberal. And even after adjusting for everything observable, there is a lot of heterogeneity. So if you then look at those same individuals a year later, you find a lot of correlation between those two things, that the more likely it was that your physician prescribed opioids controlling for everything else we see, the more likely you are to still be on them a year later. And that has strong implications for thinking about how much of our efforts to reduce opioid overuse and reduce opioid overdose and death needs to come on the physician side and on the provider side. This is my favorite. I say this about every paper, but this one's really my favorite. So we had a lot more contact tracing on COVID-19, right? This is you test positive, and then everybody near you gets told you may have come in contact with someone who had COVID-19. So in the UK, this was done in a centralized fashion. And it turns out that some of you are old enough to remember this. Microsoft Excel used to top out like 65,000 rows. And so the version of Excel they were using actually topped out and deleted a bunch of observations. There's no error, it just deletes all the observations. And so people miss being contact traced. And the way you see that is if you look at, this is in PNAS from 2 years ago, if you look at COVID cases by test date, you see this relatively linear increase. And if you look at by reporting date, the data kind of stops increasing and then jumps when they catch up. So if you look at the regions in England these were all from, you find it was not evenly distributed. Some regions happen to randomly miss a lot of cases, and some happen to randomly miss not so many. And you can then look at regions that had above median versus below median missed cases contact traced, and you find more COVID cases in the places that were above median afterwards, and more deaths. Meaning this is some of the best evidence that we had during COVID that contact tracing actually made a substantial difference in reducing both cases and deaths. So I'm a reproductive healthcare economist in a lot of my research, something that has become ever more important and ever more salient in the last couple of years. And so I want to talk now a little bit about the turnaway study. This is a study that outside economics that sociologists and others did, where they went to women. I'm going to say women here because this paper is about women. I do want to acknowledge that people who I don't identify as women can still be pregnant, but I also want to accurately represent the results of the paper that I'm talking about. Women in 30 abortion clinics across the US who just met or just missed the gestational cutoff for an abortion. And they can then follow these women over the last 15 years almost and see how their lives have been different, see how their families have been different. So there are many papers in this literature, but the one I want to talk about is one where two economists came along and took this data and matched it up to the Experian credit bureau files of these women. And if you're worried about confidentiality and telling Experian who attempted to get an abortion, don't worry. They bought data on 50,000 more women from a marketing firm, hid the 1,000 in the study in those 50,000, sent them all to Experian, and then got them back in a way they could then separate back out the ones for the study. This enabled two really fascinating questions. One was, if you look before the attempted abortion, so kind of in event time -1 and -2 in years, you can see that the near limit group and the turnaway group were exactly the same, that their financial distress was the same. So, you worry in these quasi-experimental settings that the individuals who just missed getting an abortion and just got one might be systematically different, that if you show up at the clinic a week too far along for an abortion, you might also not pay your bills on time. Turns out that's not true. The women look equivalent. But then after the situation, most of the women who were turned away ended up having a child, and their household financial situations declined and stayed worse for all the 5 years we could measure it. I'm trying to work with some Swedish data on abortion exception boards from 50 years ago, where we could then do this kind of study, but do it over a lifetime as opposed to only 5 years. But the point here is that this is kind of we talk a lot about social determinants of health. This is a health determinant of social, right? This is a case where not getting wanted healthcare drastically impacted someone's financial and economic situation. Okay, finally, this is one about physician income. So there's a team of economists and people working at Census that linked IRS data to CMS, Medicare's physician databases. So they linked NPIs, provider identifiers, with tax returns. And first of all, just on descriptive levels, what that shows you is that survey data, even restricted survey data, is underestimating the annual income of physicians. And one of the reasons it's underestimating is that a substantial amount of physician income is actually coming through business income as opposed to wage income, that physicians are often getting income through being the equity holders of their own practices. And so that just asking about salary actually underestimates income. But beyond these descriptives, then you can say, well, how does public policy affect physician income, right? Because when we change reimbursement rates, some may have the goal of increasing physician income, but some may have that not be the goal. And if that ends up being a consequence, that should be factored into the policymaking process and the incentive process. So they looked at the ACA fee bump, just to remind those of you who haven't read the whole ACA recently. One of the concerns was that Medicaid was reimbursing primary care providers too little, and therefore primary care providers weren't taking new Medicaid patients. And so for just 2013 and 2014, Medicaid reimbursement rates for primary care only were increased to Medicare rates. And then the idea was that then people would have a provider, have a primary care doc, and would then stay in that system. And just say that there's variation across states in how much this would help. So states like California or Michigan or New York or Florida, this would drastically increase primary care Medicaid reimbursement rates. So now what you can do is you can say, how does this affect the earnings of primary care physicians compared to non-primary care physicians who didn't have any change in their reimbursement rates? And you find actually a sustained increase in primary care, in the income of primary care physicians. That some of the transfer, not all of it, but some of it actually was going directly into the compensation of primary care physicians. Now, again, if you think that primary care physicians are relatively underpaid or there's fewer incentives to go into primary care, this might be a policy win, but at least it's one that needs to be considered. And if you stratify by the type of physician, you actually find that government-employed primary care physicians don't see anything, because as a government employee, you don't have equity shares in your practice. And self-employed physicians also have substantially more than non-self-employed. Okay. So this is just a taste of the amazing work I think that data is making possible in health economics. And I very strongly encourage you to incorporate consumption of this kind of research into your daily intellectual life. Planet Money podcasts are great. There's a great podcast called Trade-Offs. I've cited a lot of Dr. Bapujena's work, who some of you may remember visited us here in Kansas City several years ago, who's a physician and an economist at Harvard, both his podcast, Freakonomics MD, and his brand new book, Random Acts of Medicine. I don't get any kickbacks from this, so this is totally no conflict of interest here in me recommending them. I highly recommend all of these sources. And so just to say this challenge even more clearly, I think everybody should be consuming economics research, especially those of you involved in the healthcare space should be consuming health economics research. And so add a bit of this to your day, add a podcast to your commute, add something to your weekend reading. You can also get new economics working papers, and I think any educated person can read the abstract, introduction, inclusion of an economics working paper. And you can also write to me or work with me. So my syllabi for my classes are all on my website. You can send me an email and I'll send you more papers than you possibly could have wanted to read. And I'm happy to continue this conversation. So again, thank you to the organizers for including me, and I look forward to the other talks and to the conversation.
It was great. Thank you, Dr. Selesky. All right. So our next speaker, while I pull up and change my viewing here, we have the pleasure of having Sarah Story, who will be talking about strategic communications perspective, the role of data storytelling in advancing health equity conversations. So let me change. Okay. I'm not a Zoom expert, so let me just, not that.
You're not an expert, but you don't want to leave the meeting.
Exactly. I wanted,
you can share.
I want to do it so you can view that. Well, you're in the room now, but I wanted to do where you can view the speaker as they're talking,
just pull up the slides and then share it.
Mm-hmm.
Oh yeah, that's where it's at. First I need to share, and yours are probably on here, I guess.
Yeah, it's the PDF, right? Yeah.
Okay, and then if I go to I don't want that. Where's this? No. Okay. I know. I was like, I just don't remember how to get it.
They're going to see it differently than you're seeing it here, so we get to see it directly. So
Yeah, and they can click it on their own. Okay, that's fine. Yeah, fair. On the next one. All right, thank you.
Of course. Hi, everyone. There's people in the room.
Welcome.
All of you online are really missing cookies. Hi. Your hair is longer. Okay. It's so weird. So I actually put the wrong date on my calendar, and I was here yesterday. And I went home, got back into my workout clothes, hung out my dress very carefully, and was like, I'm just going to do it all over again tomorrow. And thankfully, it wasn't the same security guard who looked at me like I was absolutely crazy. I'm trying to share it in, I'm trying to share it in full screen, but I think I can page display. Here we go.
We got it.
Zoom to actual size page display. Oh, well, okay, no big deal.
You go back to that menu, it didn't say full screen mode,
Did it?
go down.
Oh, it's a whole other thing. Okay, thank you. Great, wonderful. Yes, it was real great teamwork. I'm Sarah, and I'm self-describing as a palate cleanser between your meatier and more nutritious meals. This is going to be a lot of fun. So Dr. Slusky, David, was one of the first people I met when I moved here. So I was very excited to see that he was teeing me up. Because whether we planned it, which we didn't or not, a lot of the visualizations and that storytelling that you saw Dr. Slusky present, I'm just going to assume he's okay with me calling him David. Seems like the type.
That's definitely okay.
Thank you, David. So what you saw David present, there's a lot of Davids in economics too. So there is a study about alphabetizing of last names and like Nobel Prizes, which is also a very fun natural experiment you should go look at. I am a recovering economist as well. And David was one of the first people to really just like welcome me to the region when I came here. So it's very exciting to see him on the panel. I have had a lot of career shifts in my life, but this was inspired by my shift from academia, where I was studying the economics of health inequities, to applied policy. My PhD is in public policy, but my first love was campaign communications and political organizing. And so it kind of didn't hit me until later that I was going to need to draw on a lot of those same tactics in order to do the work of health equity from a policy perspective. So when I say do the work of health equity, what I mean is there is a finite pie of resources, and your job as someone who cares about health inequities is to increase that pie and distribute those resources where they're needed the most. That doesn't mean everybody gets the same. It means that the people who need the most get the most. Whether you work in a healthcare institution, whether you're a policy influencer or a policy maker, these are some tools of the trade that might be useful for you to take all that amazing research that you saw David present and get it into the hands of people who will create change, and get it into the hands of the community to rally and advocate for change as well. So we'll talk about all of those different stakeholders. So I will contend, I've worked in the technology sector for going on 5 years now, mostly in the data storytelling space and in the data kind of visualization space. And I have learned that we do not have a lack of data. We have almost too much data for people to know what to do with. And when I'm speaking of data, I'm not even touching the trillions of data points we have from a healthcare touch perspective. I'm talking about publicly available data sets. There are about 75 to 100 publicly available data sets that policy folks use on almost a daily basis. And they are at every acronym agency you could ever think of. So you know the census, you know the American Community Survey, but you go to HUD, bless you, EPA, and you're using those to piece together this story of how health inequities are created and how they can be healed. So there's kind of three things we have to all believe. If you don't believe these things, then eat a cookie and we can debate later. Health inequities are real. They are unnatural. And I use the term inequities. I don't use the term disparities because I believe inequities are have been a choice of people, which is number two. The health inequities were created by people through the use of exclusionary policies. Another way to say this in like the health econ space, when you're going to do applied work, is that race is not a risk factor, racism is a risk factor. And so we're moving beyond just the demographic labels into actually trying to uncover some of those root causes. Number 3, you will have to convince someone of something. If you want to do the health equity work, that is not the status quo. Whether that is a DEI work group funding in your institution, whether that is you in front of Congress, you're going to have to convince someone they're going to have to sacrifice something in order to heal health inequities. And so I have worked with hundreds of public agencies trying to do this work, including non-public, not-for-profit, payers, right? They're all in this work of like trying to figure out how do we solve health equity. That was a quote unquote. And really what I learned first off in getting into this work was the words we were using are alienating people. And I'm not just talking about your residents or your patients. I'm talking about policymakers. I'm talking about electeds. And so I took the liberty of, you'll see kind of on the left-hand side, just something you might see in a standard research paper or research brief, a statistically significant relationship between race and quality adjusted life years in all urban population centers. Does anyone want to guess what reading level from a grade perspective that is?
13.
13 is very close. It's 14. So that's a 14th grade level. The one in the middle is the same thought. That's at a 9th grade reading level. And the one on the far right is going to be a 5th grade reading level. In my best practice opinion, what we'll usually use from a public agency to a resident is going to be around 8th grade, 7th or 8th grade. My hometown, where they piloted Uber because we have the most DUIs per capita in California and also consume the most fast food per capita. So we were also the pilot for Taco Bell's new menu items, which was very exciting growing up. So what a life. You can guess where I'm from later. If you don't already know, you can pop it in the chat. So, you know, when we would work in my hometown, I was a community organizer and political organizer. We would use 4th grade level and we'd often have to do it in multiple languages. So the words we're using can alienate. I also want to say I created these with ChatGPT. And if there isn't an easier way to change, like we have no excuse anymore. If you say, I don't know how to turn this from 14th grade level to 5th grade because I am too smart and too well read, so I don't know how to talk it. Their AI will do that for you. And so I'm just flagging that as a really exciting creative use of ChatGPT, which like didn't even exist when I wrote a book chapter in Talking Health, which is a book about health communication and public health and health equity. I do not get any money from this either, just like David doesn't get any money from his podcast recommendations. Sure. Yeah. Oh, that's the camera. It's called Talking Health. It's published by the de Beaumont Foundation. The subtitle is A New Way to Communicate About Public Health. And a lot of what I'm going to talk about here in the next 6 minutes, you can read more about in that book. It's pretty cheap. I don't know who's getting paid off that book, honestly. Okay, so you'll notice in that chapter, it kind of lays it out like you're doing a marketing campaign. And that really is it sounds soulless, but when you think about the most persuasive people in this country or even in the world, it's going to be advertisers. You're going back to Mad Men. And if we're doing the work of public health and health equity, healthcare innovation, we are up against a lot of forces who are very, very good at marketing. And in my field of public health, we have been less good at marketing ourselves. And so one of the things I always tell people, if I was writing let's say a research brief for electeds, or I was writing like a public report based on David's Uber study, I would want to think very long and hard about the first line of that report. And I know you may be looking at me like, I came here to do big data talk. I want to talk about machine learning and I want to talk about all this. And it's like the first line of the thing you're trying to say is the most important part of the entire report. So I'm already thinking if I was going to translate David's research into something that I'm going to publish or I'm going to get to electeds, I'm going to think about that first line and I'm going to think about the way I'm framing this work. Narrative framing, which we have no time to go through here, which is kind of this flipping the script. I saw some great research recently about how audiences are responding kind of post-pandemic to different frames when it comes to health equity. And pre-pandemic and even during the pandemic, there was a lot of resonance around kind of like injustice, inequity. Like that, like people were really moved and they were like, audiences were really moved by this idea of deprivation and justice and fighting for things. And now, given like the world weariness that a lot of us are in, there's more of this narrative of abundance and like moving towards hope, a real hero's journey, that almost every academic paper can be turned into a hero's journey story very easily. And if you can't do it, you can email me and I'll help you. But the find your hook is really critical when it comes to actually doing consensus building around health equity issues. And it really is about finding something that no matter where someone is on the political spectrum, they agree with that statement. And so there are a lot of statements I've seen. I've worked all over the country on this. One of the statements that works the best, no matter how people vote, is that prevention is a fiscally responsible policy choice. Everybody loves that. It scores so well. As well, number two is everybody deserves an opportunity to thrive. Not everybody deserves good health. And health inequities are real. And look at all these ways we screwed up as people. It really is about opportunity and this fiscal responsibility that actually plays really well inside institutions as well as in government policy. So lastly, I'm talking, I have 2 minutes and 45 seconds. I want to talk about looks. You're probably sitting there like, I came here for p-values. And I will tell you that when I left academia, no one cared about my statistical significance. And I was so hurt having trained in economics that nobody cared about my p-values or my coefficients or my odds ratios or my survival curves. They really wanted to know, like, is this something that I'm going to enjoy consuming? And I realized that looks did actually matter. And we've tested it over time as to like what people respond to. It's very simple. First impressions matter, simplicity matters. I recently read a study, I think it was out of Stanford, where they were like baiting people into rage clicking when graphics wouldn't load. And that someone waiting for a data visualization will only wait a maximum of 3 seconds for that to load before they move on to something else. And so these are just little tweaks we think about when we're thinking about inclusivity and we're thinking about accessibility. I'm also thinking about how likely is it that someone's going to understand that visualization in less than 3 seconds before they move on. And so there's more on this in this chapter and all over the place, but I'm telling you, like, someone in your organization needs to take a data visualization class. When you only have 15 minutes, you come up here and tell folks like how many different classes you need to take. If there's one somebody needs to take, it's that one. There's an amazing course run by Eric Roche, who used to be here in Kansas City, and it's called Your Charts Suck. And it's like a Tufte course, if you've ever taken a Tufte data visualization course, but it's done in one day and it's very funny, and he offers it online as well. Here's 2 examples, one being pretty ugly and the other being not so ugly, through Lawrence Douglas County in there for our KU friends. On the left, you'll see the adopted budget from the city of New York. That's the actual online version of it. And it just says capital. And I thought like this was so indicative of like public bureaucracy that I always have to use it. And then you're going to see here another government report. This is pulled from an interactive website that they created in Lawrence Douglas County Public Health. And instead of calling it the Lawrence Douglas County Health Equity Needs Assessment Report, which is the technical name, they just gave it a new name. They just like rebranded the whole thing. This is really beautiful. This is all their idea. Healthier together. And I just like, oh, it doesn't even have to say it's a report. It just has something beautiful, and I'm very proud of them. And so this is the last thing I'm going to say is that we are so dogmatic sometimes about what we've learned about how is the best way to visualize data. And one of the things I always learned, I was getting my degree in epidemiology way back when, was like, oh, zero, it has to be a zero axis or you're lying with statistics. And so I adopted that. And then even when I was working for the public health department, we would do these epi reports and we would look at things like HIV cases and HIV attributed deaths. And maybe if you had a zero axis, you know, that line goes like this. But when you zoom in and we do the calculations, those 1,500 people we lost every year. And I was like, that's 1,500 humans that we lost because we were so obsessed with this thing that we were told if we don't do this, we're not legitimate scientists. And so we were very torn because we wanted to, you know, pay homage to the fact that there is a zero axis and yes, cases are up here. So we present it both ways. We present it with a zero and then we present it zoomed in. So we're really honoring those lives that we've lost because behind every one of those data points is an actual story. And I think when we're talking about aesthetics and we're talking about words and storytelling, it is important to always come back to that kernel of truth that like when we talk about data, we're talking about people and their stories too. So I'm going to cut it there. If you want to talk more about the process, please feel free to reach out. I put my personal email address. I mean, I'm always changing jobs and careers, so you never know where to find me, but this is my Gmail, which means you're always going to find me here. And you're welcome to reach out. And we can chat more about this at a later time. So I'll pass it back to you. Thank you.
That was beautiful. Thank you very much, Sarah. And so now I have the privilege of introducing our next presenter. Oh, and one other thing before I do is anyone, make sure you're writing down some questions. We will have Q&A at the end. And anyone online, you can feel free to, you know, pop them in the chat or at the end, we'll bring those up as well. So I'm gonna do a new share here. No, it's still on screen. It's green. No, I'm not. Apparently, I'm like really untechy today.
I think we just
Extra.
grabbed that one there. That worked.
Yeah, you're like, this is painful to watch. All right, so, and now I'm going to introduce, we have Dr. Russ Waitman, who's going to be talking about Picornet. So the floor is yours.
All right, thank you. I just want to show of hands. I can only see the room. How many people have heard of the Patient-Centered Outcomes Research Institute, or PCORI? Okay, and how many have heard of the Picornet? Okay, great. So this will be a good talk. This is gonna be pretty high level, so I'm not gonna go into p-values. So Picornet was created in 2013 as a funding announcement. And PCORI was this new institute created by the Accountable Care Act, or Obamacare. Okay, everybody remembers that, right? 2010. So they said instead of the impact on healthcare from a changing in Medicare reimbursement, they focused also on, we want a new agency to fund research that typically is not done by the NIH. Meaning we want to focus on things that are patient-centered and largely looking at comparative effectiveness. Drug companies aren't going to compare drug A against drug B. That's up to this new agency to kind of increase the amount of comparative effectiveness research. So I would ask you, and a lot of this for people who is not a researcher, show of hands, okay? So when you think about it, you know, research is cool. Like, okay, they've got a new drug to cure something. But a lot of times in your real world where you're not waiting on the new thing. You're like, I got things like right now. Is it better to exercise or is it better to take this new Wegovy drug, right? That would be like a classic comparative effectiveness. John Spurse is a cardiologist. He's got a lot of tools in his toolbox and he could compare, is this a better tool for this type of patient versus that one? So that was what I would say when you think about what is this comparative effectiveness. It's trying to say, I got different options. Which one would be better for me? And so PCORI is interested in funding that. So in the course of this agency being started up, they said, well, clinical research is kind of great, but it takes a long time. A lot of times the research happening is being done to show that it works for sure, And so you'll define the groups of people you study to be not representative of the broader population in America. And so they wanted to think about, could we build a network of places that, another analogy I like to use is when people do these big trials for new drugs, they'll build up like an apparatus, kind of like a play, where they'll build a set, they'll have a data coordinating center, they'll get all the actors to come. And then when they're done, they'll tear it all down. So it's kind of built on the model that you build up this whole thing for this big trial, and then a lot of times you tear it down. So the hope was if you could build a network, maybe by a network of people working together, you could run these studies, both looking at data, but also using data to inform or power how you do research trials more effectively. So it has what are called clinical research networks. So it's kind of like the United States. You have different networks around the country. You have patient partners involved, and you have a coordinating center, and that's the network. And it kind of also brings in other data sources. So in addition to having data from healthcare systems, it has other data that a lot of people will link in. And it has a front door. So this is different than if you work in some data collaborations. A lot of times if you know buddies, you'll work on stuff and say, hey, can you share this with me? And you might have frustration. You think somebody will share, maybe they will, maybe they won't. So PCORnet has a front door process. So everybody can go, who's a person thinking of an idea, they can go to the front door and receive preliminary senses of who's out there who might be interested and help them work on their proposals. We also, as projects get funded, they can apply for study designation, like a good housekeeping seal of approval. And that way the network as a whole will just watch and see how's your study doing. And you get to present a couple times a year. And if people are having problems, kind of get attention from everybody to focus on helping you with your study. So this is a map of PCORnet right now. And you'll see the different names of the networks. I represent the Greater Plains Collaborative in the middle, the orange people. And I'll just make a note, we just got through, it's not yet official, but each of the networks was allowed to add 1 to 2 sites in their network. And we were specifically told by PCORI, you don't have a lot of people on the West Coast, and you're kind of missing the Northeast. So we responded to that in our network by proposing to add UCLA and a small hospital in Boston called Massachusetts General Hospital in Brigham, which PCORI rejected. They actually turned on MGB. They said, you guys didn't put enough attention into community engagement, and I don't understand your diversity. So we'll revisit that another day. But they said, okay, move ahead with UCLA. Yeah, there are people in Los Angeles. So there you go. So as we're thinking about who you can work with, we've got good representation here with KU and MU and WashU in the state of Missouri in the network. If you're not familiar, another thing to think about with data is there's some data in healthcare delivery processes which lend themselves well to standardizing. So knowing if you're dead or alive, what your diagnoses are, what drugs you're on, what labs, what procedures, what are your basic demographics. So almost everybody in the network has that reasonably well. Although when you do a study, has anybody ever heard that expression? If you don't look at data, it rots. So if you hope somebody says, oh yeah, I got it. But if you never have investigators come along and use it, you're like, is it really good, or is it just get dusty in the corner? So that's something to pay attention to. But then different networks have advanced in other ways. I would argue now most people can geocode their data, which means they can take an address and they can say, aha, it's this on the map of the world. And based on that, I know that they live in an urban area or a rural area. There's a lot of information on social determinants of health increasingly coming into the network. Our network is focused on integrating tumor registries about cancer cases, so we got a lot of detail there. There's a lot of effort on increasing patient-reported outcome measures. Specifically, the network as a whole is going to really try to make sure that the standard instruments for assessing depression are incorporated. And you get the idea. Another area for our network and others is doing what's called natural language processing on text notes. So a lot of good knowledge is in doctors' notes, but it's not structured. And you don't want to just hand it over to somebody because it may contain protected health information. So there's an effort to kind of streamline and clean that up. This is a picture I just want to share with you high level, because if you get in this data space, it's probably obvious to you, especially on the industry side, what the Food and Drug Administration says is really important. And so about a year and a half back, they put out a draft guidance document called Real World Data assessing electronic healthcare records and claims, and can it support regulatory decision making? So that's a big thing. Like, they're really dependent upon people hand entering everything again into what are called case report forms to be the core data they use to evaluate whether a drug is effective. And everybody's thinking, you know, why am I typing data that's in the electronic healthcare record and moving it over there? So they're doing guidance and just thinking about what are the processes you go through to go from source data information in the health record, what other things you might link like claims, death certificates, and registries, what goes into clinical repositories, when do you standardize it into, like the prior slide, a common data model, and then where does the data set finally sit for that study? So PCORnet is kind of also well suited to helping the FDA, as it is CDC. So I didn't mention we have a CDC speaker, but PCORnet has also been used by the CDC for COVID surveillance. I'm going to give this slide, though, too. The topic is phase 3. So where are we? Where have we been? Where are we? So if I look back on my career in informatics, I was at Vanderbilt University for a long time, and we were building some of the first electronic healthcare record systems, and we could do great decision support in the clinical workflow. But very few people had electronic healthcare records, and they weren't standardized. So you couldn't call a drug and mathematically know it's like lisinopril here and there. You had to use commercial databases. They were different in terms of what they even called a basic drug. And so when the High Tech Act got adopted before Obamacare, it led to billions of dollars benefiting companies like Epic and Cerner to get people to buy these things. And the premise was you had to have them be meaningful use, meaning they could interoperate. So those were created. And then the National Institutes of Health and us involved in NIH funded research started to think about how do we harness that new data to advance discovery. Then you saw PCORnet came along and other national networks. Has anyone ever heard of the All of Us initiative for cancer, right? So that came along around the same time. Other networks that started to get into this business about how do I get people to trust and be better at governing and sharing data? Because a lot of times health systems are like, I don't want to share data with anybody. So that was kind of what evolved over this time frame. Then we had something happen. There was an election, people may remember. And for PCORnet, this was a big deal, right? Because President Trump ran on the campaign that I'm going to repeal Obamacare. And what was created by Obamacare? PCORI. So we were in a crisis mode of like, what will happen to the network? So we kind of kept the network going, and we launched a major trial called Preventable, despite this uncertainty, looking at can you control cholesterol, not to just lower cholesterol, but can you actually reduce cognitive decline? So that's launched. And then PCORI got reauthorized at the beginning of 2020, and we've relaunched and keep on moving along. And so PCORI has new priorities around maternal health and intellectual disabilities given to them by Congress. We have, as noted, we're expanding the number of sites involved, and we're using more, I would say, cloud infrastructure in general. So that's kind of my general short pitch on what is PCORnet. So again, if you want to do research or just look at data, I think we're also going to be working to make more self-service tools so people and patients can start looking at data. It's an option for you. But I wanted to take some slides from PCORI itself. So they presented some things, just to remind you again, they fund studies that largely are comparative effectiveness research. So they want to look at things that can help people make better health decisions. And when they say they're a leading funder, they're funded by a little bit of money on every insured American. So they have a very large trust fund of billions of dollars, and they will typically every 3 times a year put out opportunities for up to $400 million in funding each cycle. So if you've got really good ideas in this space, it's an option to fund the type of research that typically other people don't fund. As noted, they funded the creation of this national network that does large trials. So PCORI, a lot of times, you can kind of go small to big. I tell people, start in your own backyard with your local team, but then supersize it. And depending upon their funding announcement, you can go from local to regional to national. But they love to think about things where they know the size of the study will be definitive. So they just announced this last I want to say, I think it was around May, they put out a new announcement. So if you are at if you are interested, you don't have to be at one of these institutions, by the way. You can use the network however you want. But they have a new announcement where they will fund research within PCORnet itself that uses two or more of these networks across the country. And they're specifically interested in these areas. These are kind of their priority areas in addition to maternal mortality, morbidity, and intellectual disabilities. Well, actually, they're listed right there. So there's the intellectual disabilities, and here's maternal health. Where did it go? Oh, I think it's out here somewhere. Yeah, right down there. So, and they can be big. They can be up to $10 to $12 million. And they don't all have to be a trial, a prospective study where you use, as David Slutsky said, randomized control trial. They can be natural experiments as well. So if you have ideas, let us know, or let folks at KU know or elsewhere. And I'd just like to close with, the studies that can be done are real world evidence studies, kind of using this existing data we have, studying the healthcare delivery process itself, kind of like the IQ program. You can do with this large amount of data, population health research. You can do pragmatic clinical trials. And I would say that's one of the things it does a little differently than your traditional enter everything by hand in a case report form. We'll do work where we look at who's being seen in the hospital. So this preventable study is saying, I'm going to put you on Lipitor or not. I'm going to look at the record and say, I want to recruit people over 75 who are largely healthy. And then I want to see if they would enroll in this study. And I'm going to have them enter a minimal amount of data, but then I'm going to look at their health records and their claims data to see what happens as a consequence of that. They can also be used, and they fund a lot of research just about how to engage patients themselves in research. So there's a lot of opportunities there also. So that's the overview, and glad for the discussion later.
Thank you. That was a really great overview. Thank you very much, Russ. And so now we'll move from PCORnet into CDC. And so our next speaker will provide us with a public health perspective on lessons from COVID-19 surveillance in the setting of evolving data needs. And we have Dr. Adi Gundapalli. Hopefully I didn't butcher that too bad. And the floor is yours. Looks like you've already got your slides up. So thank you.
Thank you. Are you able to hear and see me?
I'm going to work on the seeing you part.
You sound great.
Okay.
Yes, you sound great. There we go.
I did.
That's what I wanted.
I did hear too. So, well, first of all, thank you. Good afternoon, everyone. Greetings to all of you from CDC, and hope you're all staying safe during the heat wave and, gosh, coast to coast topsy-turvy weather. Right? You hear everything. Thank you very much for the invitation to visit with you all virtually today. And personally wanted to thank Pat here for the invitation, and gosh, my colleagues too. I mean, these are hard acts to follow in trying to shift from just amazing talks on economics and storytelling in PCORnet. And yes, Russ, we work closely with PCORnet at CDC. Before I start, just wanted to say I'm a federal employee, so I have no financial disclosures and no conflicts of interest, and opinions presented here are my own and do not necessarily represent the views of CDC or the US government. All right, so by way of introduction, as I'm hoping most of you know, the CDC is the nation's premier health protection agency, and CDC saves lives and protects people from health threats. And to accomplish this important public health mission, CDC needs data. And CDC conducts critical science and provides health information that protects our nation. So let's start with some really basics. In the next 10 minutes or so, I wanted to talk to you a little bit about how we've used data from healthcare, which then contributes to public health surveillance data in managing and just even understanding how the COVID-19 pandemic evolved. And I think all of you will agree this is the most significant event that has happened in our lifetime. So starting with some basic definition here, let me just make sure. There you go. So public health surveillance, there are many definitions. This one is what we like at CDC from Tacker and Berkelman in 1988. So public health surveillance is the ongoing systematic collection, analysis, and interpretation of data, closely integrated with the timely dissemination of these data to those responsible for preventing and controlling disease and injury. So the blue highlights are mine. It's really not data for the sake of data collection, but to be able to convert data, informatics 101, data to information to actionable knowledge. And that's what we strive to do here at CDC. Now, there's some enduring principles for surveillance, right? I mean, if we asked all of you or a lab or a hospital or a pharmacy or anybody and said, hey, we just need you to send us one piece of data, it'll take you 5 minutes, and just do it once, I'm sure everybody would be willing to do that. But if we start asking every day, every few hours, and more number of elements and more details, and we want to know everything, then really it has to be low burden for the data provider, right? Especially in these times. So some of the enduring principles that we try to strive for are that surveillance should be automated, low burden, timely data capture, efficient and low cost, and it should work for all types of surveillance, whether you want to look at an emergency department visit or you want to look at prescribing of a medication or deaths or cases or heat illness, heat strokes. And then it should provide background information for multiple conditions, so we can use it, reuse it for multiple cases, use cases. We should be able to encourage research and patient engagement, and I think the PCORI talk by and PCORNet talk by Russ was really very timely, which is where the heart of where we want to go is in terms of how is it helping and improving the lives of our community, not just patients, of course. And of course, any surveillance that we do, federal government has to maintain strictest privacy, confidentiality. It should work well for routine needs, so what we call peacetime, if there is ever such a thing. And then these surveillance feeds should scale and evolve during a public health emergency. So for COVID-19, we were tasked early on, and gosh, it's now nearly 3-4 years now into this whole making here, looking at how do we look at COVID-19, how is it evolving, and what can we learn from it, and then how can we mitigate it, right? So these are just some of the streams of data that we had to work on from about, we have many of these in place before COVID, but we had to adapt and adopt it and really scale it to COVID. So first is case and death surveillance, right? Everybody wanted to know how many cases are there, how many people are dying from COVID. They sound simple, but it's actually quite difficult to figure out the death due to COVID. Syndromic surveillance is sort of like looking at influenza-like illness or a respiratory illness and see if that was increasing in an area, and we have systems to do that. Laboratory test results were, in the beginning, very difficult to get because there were limited test data, tests available, and then it really picked up. And now it's again a problem because laboratory tests, the testing for COVID is done at home and nobody reports those, right? So come full circle. And then during the life cycle of COVID, we had to deal with variants, right? The genomic data for the virus. In all of this, we did not want to forget the patient, the vulnerable, and any disproportionately affected population. So we needed healthcare data to see what was going on. Now, of course, as you all know, for long COVID, healthcare data are essential. Vaccination, it is the largest vaccine campaign in our country by far, right? 640 million doses of a vaccine given within 2 to 3 years. And we had to track it, not just to see that we were giving so many, but where we were not giving the vaccines, right? Who was not getting it? Is it this region or that? And then early on in the pandemic, when the shutdown occurred, we were looking at mobility and social impact data to see how is that, is that effective? And mobility was way down, of course, during the shutdown. And for all of these, we needed nationally representative data, and we should never, ever forget disproportionately affected populations, because there were really vulnerable and extreme outcomes in the elderly, very young, immunocompromised, etc. And this is all done at the federal level, but we know very well, and the first premise of public health is that all primary public health action is local, right? So whatever we are able to do or give guidance at the federal level, it's extremely important that the primary action is done locally. So it's really state, tribal, local, and territorial jurisdictions, where we abbreviate that as STLT partners, who are the lifeblood of our public health system here in this country. And our perspective from the federal is to support STLT, provide situational awareness, and inform guidance and policy. So with the best data we have at the time, be able to synthesize it and provide it to our clinicians and our public health practitioners and to the public, of course, and the community to say, this is what we think it is. So, and that unfortunately had to change as we learned more during the COVID pandemic. And of course, all this to prevent and mitigate, adverse events and severe outcomes from COVID. And this was a deployment that there were incredible challenges. There were opportunities because we did have existing systems, but the challenges were adapting, adopting, and scaling these. So immediate needs, our colleagues from the influenza division in the National Center for Immunization and Respiratory Diseases, which have been doing influenza surveillance for decades, were able to quickly adapt those systems to look for COVID, which was influenza-like illness in the beginning, right? So that's how it is. And for each of these systems, we had to evaluate what the data needs were, what for each question that we needed to answer. And sometimes, and many times, we had to establish new data flows that didn't exist. And gosh, trying to build a system in peacetime is difficult enough. During pandemic, it was even more, because even if we had the money and the resources, it's really getting people together who's not fatigued and who has the time to think about these. And looking at it through the data life cycle, from acquisition all the way to visualization of data. And the data were just not simple at all. I mean, these are, the size and dimensionality is just extremely complex when you get healthcare data and individual health data and of course, never to forget disproportionately affected populations. And for all of this, the system had to give you a true national picture, right? So there's no one button you can press and get a full view of the country. We literally had to stitch together a view for the country to the best possible that we could do. And this is how it evolved. Now, the bar graphs here are, unfortunately, but it tells a very great story here, are actually weekly deaths reported to CDC. So you can see all the way from February, March 2020 at the very left of the x-axis, and then to about May here. So just a little bit, a month or two ago here. And you can see the deaths mirrored the cases and went in waves. And gosh, each of these during this time, what we've learned is just evolving and more complex needs. Like early, it was early case reporting, diagnostic testing when testing wasn't widely available, then cases, deaths, hospitalization, laboratory data, and hotspots. Where was it going to break out next? Could we actually put mitigation measures there? And then myriad presentations started occurring in 2021. You remember COVID toes, COVID this, COVID skin, multi-system inflammatory syndrome among children, which fortunately now has fallen off the face of clinical care with vaccine and all of that. And then during this time, health disparities, right? I mean, it was unfortunate, but as occurred over decades here, we saw again a health disparity, disproportionately affected populations here. And then as we got the vaccines up and running and huge uptake of the vaccine campaign, we started seeing breakthrough infections. So that is, those who had the vaccine still got an infection, though luckily it was milder, and vaccines prevent serious disease. So please, if all of you have not had the vaccine or if you're due for a booster, please consider that. And we needed to look at vaccine effectiveness. We needed to provide the data, not just say, trust us, this is what it is, but to show the data about vaccine effectiveness, decrease in hospitalization and severe outcomes, etc. So even one death due to COVID is too many, but you can see now that we have really come down in terms of the weekly deaths. And so evolving needs are extremely difficult to cater to when the complexity keeps going. And gosh, we had such immense teamwork and support to be able to do this. We learned several lessons. The first one, which I'll share with you, and which may come as a surprise to you, but sharing of surveillance data, for example, from our STLT colleagues, that's the state, local, tribal jurisdictions, is actually voluntary. So we have no authority. CDC has no data authority to say you shall send these data. We were able to do that only for COVID test results by order of the Secretary of HHS. But all of it is voluntary, and that's how we've amazing relationships with our colleagues there, where they're able to share those data with us. So it's still voluntary. CDC, we know very clearly, is a steward of surveillance data. So we don't own the data, so we have to be very cautious about privacy and confidentiality, even with de-identified data. We do not get personally identified information for the most part. And we are then bound to respond to public and FOIA requests, so that we will release those data if a FOIA request comes, because they become federal record. And that was a very challenging part where we had to work closely with our STLT partners to say, once it's submitted, whatever you did becomes federal record. So how can we do this? And we had to release the data, but we actually released that with privacy protections in there and minimize risk of re-identification, etc. And giving a situational awareness to ourselves and to leadership and policymakers is quite challenging. So real time versus in-depth. So you balance that you'll get some data from last night and 2 days ago, but it'll be very superficial, and you'll know just maybe the age and the sex at birth. So if you want to know all the details about the patient, how sick they were and what their comorbidities were, gosh, you'll have to wait several days, if not weeks, to be able to get those data. So balancing availability and currency of data with timeliness and completeness. And even during that time, as you've seen, and if you may recall, we didn't have race and ethnicity for all the cases. So that was a big deal. We could not tell with certainty where the disproportionately affected population was on that. Partnerships are essential. U.S. government cannot do anything alone. CDC definitely not. So we depend on partnerships within U.S. government, private industry, academic, and the community. And we need funding for this. So initial and sustained funding. And then, as I said, stitching together a national picture is easier said than done. And staffing. I mean, we are always looking for good people and talent to come and stay in the federal government, which is very difficult to attract them and retain them, because there's so much competition for good talent, especially with public health, epidemiology, computer scientists, data scientists, etc. Now, future needs. So we really are envisioning and reimagining the public health data ecosystem. So we're looking at local, regional, and national surveillance investments that are strategic and deliberate. And the partnership is very strong with our state and territorial local jurisdiction partners here. But there are areas of improvement, and Russ mentioned that in terms of the electronic health records, and that our systems are very rarely interoperable, meaning, if you send the date of birth in one way here, you have to do it in the same way in a second system. So at least we can semantically, collate those. And it is tricky. Not all the time you get those exact same standards are applied or looked. So it's very important. And in all of this, reporting burden. I mean, on healthcare and public health, when they're exhausted, they're underfunded and overworked, for us to come and say, why don't you send us some more data elements? Why don't you send us this? It's just a very difficult ask on our part. And we do need to make insights by linking individuals' data across and within data sets, and that's easier said than done because we don't have personally identifiable information. So, and longitudinal healthcare, that became very important early on outcomes, but then now even more with regard to long COVID, etc. And as I said, skilled workforce recruitment and retention is always a challenge. So, and we always need to understand better aspects of the illness. So just having superficial surveillance knowledge is not enough. And for that, healthcare data domains, what Russ told you about in terms of patient-generated data, outpatient, inpatient discharge data, laboratory, pharmacy, vaccine data, post-acute care setting, meaning if you were admitted to the hospital or the ICU, what happened after that? Did you go to the nursing home? Did you do well? Unfortunately, did you pass away there? Or did you get readmitted? Those are very difficult to follow. in a large system. And I know the PCORnet has been working very hard on it. So we do depend on academic and healthcare industry partnerships. But all is not lost. We do have some potential solutions. In the last year, we've released a public health data strategy that supports partners across the public health ecosystem. So, and we are working very closely and very fortunate that these were developed with our partners and they're embraced by our partners. And so the idea is to have greater access to critical information on public health emergencies. And then identify and adopt ready-to-use tools because there's such variability among our STLT partners. Some are extremely well funded and well resourced, and others are smaller departments. And so trying to give them all the kinds of tools that they need for their day-to-day work. And prioritizing data and technology investments so that whatever we do with limited resources, we get the best return on investment. And trying to see if we can streamline and planned efforts. So look at milestones and then re-up them and then go into a 3-year chance on that. And then understand where and how to access richer public health data on demand to inform decision making, such as our partners in academia. I'll leave you with this last slide to show you just some of the complexity. This is also available on the web, and you can look for that public health data, but just see the players and the complexity of how data has to move to really show what happens in interconnected public health data. I'll stop here, and again, thank you for the opportunity, and really great to visit with you all and to my colleagues on the panel. I'll hand it back to the moderator. Thank you. Over.
All right, thank you all. I am going to turn it over in just like half a second to my colleague, John Spertus behind me. But before I do so, I just also wanted to give one thank you to, which I had not yet done, to our newest sponsor for these forums. We're very excited that Health Forward, and we also have a representative in the room, has sponsored these forums. And so we just wanted to give a call out to them and thank them. But, and I also wanted to do one last thing because before we break is just reminding everyone of our upcoming schedule that we have for these forums and our next forum, which is September 21st on novel strategies to incentivize value-based healthcare. But with that pause, and sorry, it was a little bit of a out of order, I'll turn it to John Spertus, who will lead us through some Q&A. Let me, I guess, view everyone. You can see people.
Thanks.
Yeah.
Well, first of all, I'm John Spertus. I work with Pat and Stacy in trying to support this innovative strategy to improve the way we deliver healthcare in Kansas City. And normally these forums focus on some specific challenge we're facing, and yet this one was very different. It was really about the infrastructure of trying to understand health. And I really liked it. I mean, of course, I'm a research geek, so this may appeal a lot to me. And if I had my druthers, and knowing how well you all presented, I probably would have organized this a little bit differently to start with Adel and talk about sort of the pressing need for healthcare data, and nothing sort of highlights that like COVID. Then to have Russ figure out sort of how can we start to think creatively about addressing that, and the discussion and the infrastructure, the work you're doing for PCORnet is amazing. Then I think I would have had David talk about, I mean, those were some of the most creative studies to leverage data to come up with, new and novel insights. And I definitely, we run a training program for clinical scholars, people who are committing their career to try to do academic research to improve the delivery of healthcare. And I'd love to have you do that. And then Sarah, your way of trying to distill and frame and communicate data, because if people don't understand what you've discovered and they aren't motivated to act on it, what are you doing? I mean, getting a publication isn't nearly as gratifying as really inspiring people to change and improve the way we deliver healthcare. So had I learned from you how to present things better up front, I would have reorganized the whole session and had it go differently. And, I think there are 14 people online, there are 20 here. So the people online, please sort of unmute and speak up. Otherwise, I'm going to start to field questions from the people that are before us. But I did want to just ask one thing that always challenges me. And, when we are getting more and more and more data coming from more and more disparate sources, it's sometimes very hard to know where are the gaps? Like, are these data valid or not? We have very sophisticated ways of analyzing data. We can come up with very concrete conclusions. And yet, the source of some of this data, for example, coming from the EMR, as Picornet has done such an amazing job, does that contribute to inequities by systematically minimizing the insights of the experience of people who don't have access to the healthcare systems that are contributing to those registries? How are we supposed to, as data gets bigger and as analytic techniques get stronger, how are we going to critically evaluate some of the biases our work might be introducing? And I know that's a complex question. I'm sure you've heard it a million times, but I haven't heard a compelling answer. So I would love if Adel or Russ want to take a first stab at it. And Sarah, you've spent so much time thinking about inequities and how, as a health economist, you might be actually worsening the problem in using with the data you're using. I'd love to hear just a little bit of discussion from all of you about that. Russ?
Yeah, I mean, I would say the first step is knowing you have a problem. So I think there's increased interest in applying methods to know how biased your sample is. We're actually working on a proposal for the National Institute of Health or that Institute on Aging for Alzheimer's real world data platform that would build upon some of the COVID surveillance work as well as Picornet. And it specifically has health disparities cores and a community engagement core with specific tasks on how to develop the appropriate methods for looking at data bias, but also algorithmic methods biases in looking at data. I would say too, though, that there are different types of partners with different types of data that can get at that. So there are some networks, notably in Picornet, there's a network called Advance based out of Ocean in the West Coast that has a lot of safety net clinics. Now they may not have as comprehensive data as a full service medical center, but that's one option. And then the other thing that's kind of interesting is, when you get over 65 and you're on Medicare, you see a lot more probably people broadly enrolled in the Medicare program. So I think it's a continued area of work, but that's probably in a nutshell. I think there's both the appreciation of the problem, looking at how biased you are. In that example of the National Institutes on Aging effort, they talk about another bias, which is you may want to be unbiased, but sometimes it's really hard to reach vulnerable populations. So at the end of the day, will the funder budget to go reach those people? Does that make sense to people? So like we did a study on reaching people with Down syndrome to look at their self-determination and link up data. And you just realize when they're a child and they've got a very engaged parent, it's easy-ish. But when you get to people living in group living situations, where the person with the power of attorney may not be in that group living home, it's a really hard to reach population. So, there aren't necessarily easy answers there.
One thing that you said that I really liked is engaging with the community partners to help identify the gaps. I'm a cardiologist. Sarah was talking about widely available data. There's the National Inpatient Registry, you could get download on the web. But a lot of times people ask questions like, I wonder how, men and women access differently atrial fibrillation. And if you don't know that the vast majority of those procedures is done as an outpatient, will never enter an inpatient registry, you wouldn't know. So somehow engaging the community and the people to actually give you very common sense things that we just never would think about is actually a great strategy. I really like that. Sarah, you look like you're about to add to that.
No, I have so much to say that I'm not going to say anything.
Well, can you give us a high level elevator pitch?
I wonder how many folks maybe in your network and the proponent, let's say, have taken an implicit association test. I mean, I feel like it all starts with us in that way. And so anything bigger than that, I feel like there's like a chokehold that happens when I don't face my own biases as a person and take those into my work. I'm going to take them into my work unless I disrupt them on an individual level before I go in and start doing, because then I start to see things differently. It opens up blind spots to me. I was on the licensing board for Missouri physicians for 6 years. And one of the things we used to do was put the race of the complainant in the briefs to the board. But there was no reason for that. And until we kind of faced that, we were potentially introducing bias in our decision-making without even realizing it. So I don't know. That's all I'm gonna say there.
Okay.
Yeah.
Well, it's a good point. I mean, I think David comes up with a lot of great questions and interesting ideas, but if you bring a very biased frame to that, it might really sway how you approach some of those. Anybody on the conference call want to address that? Adel? David?
I think, to me, one of the things that those linkages I showed are really, really hard. And they're really hard partly because they get into these chicken games of somebody has to be willing to spend the time to figure out how to share their data in a way that is consistent with their values, but outside their comfort zone. Right. And I've made like numerous of these multi-party charts about like, okay, you're going to take the identifiers and the health data and separate them, send the identifiers and a key to the other data provider. They're going to merge their data in, take out the identifiers and just send their data and the key back to another party. That's like putting these things together so we can both maintain people's privacy and not identify them, but also ask broader questions about the role of health and healthcare in our entire lives. It moves in very, very small pieces. And like the census project I mentioned, you need a very, very well-meaning entrepreneurial public employee willing to help and empowered to help. And we're just, the Scandinavian countries do this great, and we don't do this so well. And we're just barely getting to the point of being able to do this better.
Well, it is true. You mentioned Scandinavia, Taiwan. I mean, some health systems have, single payer health systems basically have all the data on everybody and could be very well positioned to, address and respond to a lot of these kinds of questions in a way that we really spend a lot of time creating charts about following and protecting HIPAA information that make it very, very challenging to get at and to understand in real time some of the information that could really help us proactively respond and deliver better healthcare. So it's a challenge. I love dominating the conversation, but that's unfair to those of you who came. Other questions for the group?
You can see Jonathan's chat. It says a bunch of new messages.
Yeah, it's more.
Is there anything?
I think there's just praise for all the speakers. You're all getting a lot of praise, and we just don't want to. Oh wait, no, there are more. Yeah, I think most of it is just praise for the speakers and resources with the PCORI announcements. James, you're struggling with a very unique aspect now of how to think about patient needs. And is there anything you've learned here, particularly through some of the NLP work that's going on, that might be important as you think about how to improve the, equity and ethics of healthcare?
Well, I think the questions are really relevant to the ethics questions that we encounter wherein now that we're employing tools that have these machine learning algorithms behind them, it just exacerbates all of these potential issues that we've spoken about today, and will require new resources and new thinking. So I don't know where I'm at exactly, a little more maybe unsettled than when I walked in.
I'll ask you, Russ, you're doing a lot of work with natural language processing. And as an old time clinician who's used to writing, long notes in a page, and then with early EMRs, and we would sort of write long notes. Now, when I round, I mean, the fellows are just cutting and pasting the note from one to one. They're no longer writing. I mean, we used to write, like, what did we think was going on? What were the factors that supported or refuted this diagnostic? What therapeutic plan would we do as we learned the next test? And how did we think that other patient-centered issues, transportation, food insecurity, whatever, would influence the best way to care for this patient? And now the notes are, I don't know, they just all cut and paste form charts, I guess pretty soon Chat GPT is going to be generating it. Is it diminishing the value of natural language processing and trying to extract rich data from the notes? Or do you still feel like there's a lot of important information being gleaned? And do you worry about how it varies from provider to provider in how they describe things?
So I would say I personally don't do a lot of natural language processing. I'm more setting up the table. So there's a lot of complexity into just getting the hand on the right note that is under recognized. But for the notes in general, you're right. A lot of note bloat has happened where you're pulling in structured data into the note and regurgitating it over and over again because it's so easy to do. And there's discussions around, can ChatGPT just author a note for you? That said, if you look at patient-centered issues like dementia development, they're really still to this day, I mean, in an ambulatory note, well crafted, it will have some glimmer of a signal about that is just completely lacking anywhere else, right?
Oh, no question.
So that's where I think the art is. There's also some things where even though there's a lot of structured electronic data, there may be some things at the end of the day as it goes from a commercial system that reports variants or reports a lab test, or less likely a lab, but more likely a pulmonary function test, where the fact that the physician, she may mention that value in a note, and it's not a big task to just say, do I find this unique phrase? I think that can be very valuable. That otherwise, while we all wish it was all structured, we know that some system somewhere has it highly structured, having that ability to go pull those out is still valuable. But yeah, the whole history of, the Larry Weed view of how you write a note right and what's happening now is kind of interesting. There are people looking at kind of the evolution of how notes have changed pre and post EMRs.
That is. Well, I want to thank everybody for participating. I think it was a terrific for me, it was terrific because I think thinking about the infrastructure of how we can gain knowledge and learning a bit about how we can better communicate it is very important. And ultimately, it's the quality of the questions we ask and how we act upon that knowledge that's so important. And so this, again, is a slightly different type of community forum, really thinking about what do we need to understand healthcare and where does that data exist? And then how can we best leverage that data and communicate it is, I think, very important. Next time, we're going to be talking about how you change healthcare delivery. And, it is incredibly difficult. How do you create the right incentives? Every nurse, every, medical assistant, every doctor goes to work every day trying to do a really good job. And the bureaucracy and the sort of documentation challenges, the barriers to change how we do it, that people are leaving exhausted and just trying to get home. And there's a lot written on the 75th anniversary of the British healthcare system about the complete burnout and lack of infrastructure. And when you take such a committed but such an overworked and overtasked workforce, and then you want them to start changing the way they deliver care to improve its evidence base, its value, its equity, whatever, it's very, very, very difficult. And we launched these QVIC projects that you heard about briefly in transitions of care for heart failure and opioid crisis in the ED to try and learn as a community how we're going to think about redesigning to improve the value and equity of healthcare. And I am very much looking forward to the next presentation because it's really going to, we'll learn from others how they're trying to accomplish that. And I think that, again, it's more of an infrastructural piece rather than talking about maternal health or mental health or cardiovascular prevention that we've talked about in other forums, to really focus on here. It was about the data and the learning and leveraging data to generate knowledge. It's going to be about, if you have knowledge and you want to change the way you deliver care, what are some strategies we can start to think about to do it? So I hope you'll all join us next week. And thank you so much for participating. Next September, sorry, in 2 months. Thank you so very much. And for those who are here, please have coffee, cookies, and I hope you get a chance to mingle with others who are equally committed to sort of improving the way we deliver care. Thank you so much.
Bye.
Yes. Everyone online, thanks so much for joining us. David, Dr. Gundlapari, thank you. It was wonderful.
My pleasure. Thank you. Bye.
Bye-bye.
What?
I was going to this interview.